especially the Secretary, Dr. Vipin Varki, and Dr. Jinesh, Dr. Parvez, and all for giving me this opportunity. So today, in the next 30-40 minutes, what I'm planning to discuss is about pediatric asthma. So as you know, pediatric asthma is a very commonly seen condition in our OPDs, and it is a vast subject. I have limitations to discuss it in a very short time span, but what I have planned is that I will include very practical things, those things that will be useful for us in our daily practice. So I have kept the FAQs based upon how to assess asthma in our clinics, what is the stepwise management as per the latest GINA 2022 guidelines. And as this is basically meant for general practitioners, management of acute asthma is very important. So I have included a few slides on acute asthma also, and some practical points in day-to-day practice. So I will start with how will you assess asthma. So if you refresh your memories, when you were studying, majority of us when we were studying, we have learned about the classification of asthma, like based upon the severity, like mild, intermittent, moderate, persistent, like that. But nowadays, what is used is some other a recent classification. So you just see this picture. What are the different clinical scenarios coming to us asthma before us? Either the patient may be treatment naive, means he has not been started on any long-term controller, or sometimes patient may be already getting a controller but not getting adequate relief, or sometimes patient may be coming to the first time in severe acute exacerbation. So how will you assess when the patient comes to you for the first time or when he comes to you for a review? How will you assess? So as I already mentioned, there is a shift. There's a change from the previous classification which used the severity. Nowadays, what is given more importance is how far the asthma is controlled. So we are looking for how far the control of symptoms is taking place. So that involves the assessment of the current level of clinical control, and also it gives importance to certain factors which affects the future risk of the patient for acute exacerbation. So level of control, it is very simple, nothing more. You just need to ask the patient or the parent coming before you these 4 questions. In the last 1 month, in the past 4 weeks, daytime symptoms, how many times he had more than 2 times per week? Is he having any limitation of activity? Is he having night symptoms which is awakening him from sleep? And is there a need for rescue or reliever treatment more than 2 times a week? You ask the patient these 4 questions. And if the mother is telling no for all these 4 questions, that means it is a controlled asthma. And if even one of these questions mother is telling is having one of yes, then it's a partially controlled. For example, mother is telling is having limitation of activity, then it is a partly controlled asthma. If 3 or more of these features are present, then we say this is a case of uncontrolled asthma. So this is how we classify asthma based upon the present level of control. Equally important is this risk factors for exacerbation. We should also know, are there any factors which predispose this child for an acute exacerbation? So these are some of the important points which we have to ask in history. So if these risk factors are present, we have to keep in mind that there is an increased chance for an acute exacerbation. So it includes modifiable and non-modifiable risk factors. Modifiable risk factors includes these uncontrolled asthma symptoms, the patient not taking inhaled corticosteroids properly, on spirometry if the FEV1 is low, presence of comorbidities like obesity, like that. And all these things are modifiable risk factors. And there are certain non-modifiable risk factors also. One important non-modifiable risk factor is a history of intubation. If the patient has been intubated ever intubated or is having a PICU admission for asthma, that is a very, very important non-modifiable risk factor. And more than or one severe exacerbation in the last 1 year also is very important. So if these risk factors are present, whenever we assess the patient, we have to remember that this patient, even though his symptoms are presently controlled, there is a chance for acute exacerbation more frequently. Now coming to the most important part of the talk, how will you manage asthma? So as per our GINA classification, we have been following the Global Initiative of Asthma, which is an organization which is endorsed by WHO. We have different stepwise classification for managing asthma. So the stepwise classification, and it is based upon the different age groups. For our convenience, we manage asthma based upon 3 age groups, because these different age groups, there are factors which affect the outcome of asthma vary, and the treatment also varies. There will be small variations in between these groups. So one group is less than 5 years. We have 6 to 11 years age group and 12 years and adults. Beyond 12 years, in adolescents and adults, the management is same. So less than 5 years, 6 to 11 years, and adults and adolescents. So we will start with 6 to 11-year age group. So 6 to 11-year age group, how will you manage? So what are the different steps? When will you start on step 1? You can see, as you can see here, if the symptoms are less than twice a month, we start on step 1. And if the symptoms are twice a month or more, but less than daily, then we go on to step 2. So step 1 in this age group, from 2019 onwards, 2020 onwards, there is a very, very important change. So what is advised for step 1 in the age group 6 to 11 years is that you ask the patient to take a low dose inhaled corticosteroids whenever you are taking a SABA. SABA here is salbutamol. So previously, before 2020, what was followed was that step 1, we need to take only a salbutamol. But now what is advised is that whenever you are taking salbutamol, you take a low dose inhaled corticosteroid also. Salbutamol in the inhaled form. So that is step 1. If the patient is not getting adequate control with step 1, then we have to shift to step 2. So what is step 2? Step 2 means you are giving treatment on a daily basis. That is daily low dose inhaled corticosteroids. So that is step 2. Even with step 2, even after starting the treatment on a daily basis with the daily low dose inhaled corticosteroids, if the patient is not getting control. So step 3 means for a patient who is getting symptoms most of the days or waking with asthma at least once in a week, then we have to consider step 3. So step 2 was daily low dose inhaled corticosteroid. So we have to advance that treatment in step 3. So we have different options. Either we can increase the dose of the inhaled corticosteroids. So low dose inhaled corticosteroid was used in step 2. We can either make it medium dose inhaled corticosteroid. Another option is addition of another drug. So low dose inhaled corticosteroid plus another drug which is called as LABA. LABA is long acting beta agonist. For example, formoterol. So these are the different options. Either you can increase the dose of steroid to medium dose, or you can add LABA. From 2021 onwards, there is also a third option in step 3. You can use what is called as MART. MART means a maintenance and reliever therapy together. That is, using a single inhaler, you can treat both the acute exacerbations as well as the preventive therapy. You can treat using a single inhaler. That is what is called MART. For step 3 MART, what is advised is a very low dose ICS formoterol. So that is step 3. Step 3, we have 3 options. Either increase the dose of inhaled corticosteroid to medium, or add ICS with a LABA, or use what is called as a very low dose ICS formoterol maintenance and reliever therapy. So these are the three different options we have available. We are having for the step 3. If with step 3 the patient is not improving, then we have to advance the treatment. What is advised is that you can either use a medium dose inhaled corticosteroid LABA combination or a low dose ICS formoterol MART. MART is maintenance and reliever therapy. So these are the different options for treating 6 to 11 years age group. Even at this stage, if the patient is not getting control, then it's the time to work up the patient in detail. So what you are supposed to do here is that refer the patient for phenotypic assessment that needs evaluation by a pulmonologist or by a allergy specialist. So you refer for phenotypic assessment. From this stage, the different options available, that is from step 4 onwards, the patient is not getting control. There are different options, other options available. One is tiotropium and other drugs like omalizumab and anti-IL-5 antagonists like the napolizumab. These things are not commonly used in our setup. So for a general practitioner, what we usually have to do is that usually start with the step 1. The patient is not improving, you make it daily low dose inhaled corticosteroid. Or if the patient is not improving with the step 2, you step up to step 3. Beyond that, if you are not getting adequate control, better refer to a pulmonologist or an allergy specialist. So that is about managing asthma in 6 to 11 years age group. Now coming to a few details about the drugs which I have mentioned. Tiotropium is a long-acting muscarinic antagonist. So it is advised for use from the age of 6 years now. And it is just like atropine. Atropine is a short-acting muscarinic antagonist. It is a long-acting muscarinic antagonist. So the common side effects will be almost like atropine, dry mouth, constipation, abdominal pain, etc. So that is about this tiotropium. These are some of the drugs which can be used in cases of difficult asthma in step 4 and 5 when the patients are not getting control. And majority of these are not available in our place. Only omalizumab is freely available, but it is not commonly used. Very rarely we use omalizumab in our pediatric practice. Mepolizumab, which is anti-IL-5, and dupilumab, which is anti-interleukin-4 antagonist, both are approved for use as per GINA guidelines, but these are very, very rarely used. Now coming to the age group, adults and adolescents. So for adults and adolescents, from 2021 onwards, GINA is giving 2 treatment algorithms. So based upon the reliever drug which is used, GINA is recommending 2 treatment algorithms. You can choose either of these 2 tracks, whichever you feel is comfortable for you as well as the patient, you can choose that. So for 12 years and adults, this is the track 1. So as I already told, track 1 and track 2 is based upon which reliever you are using. Not on the basis of the controller, but which reliever you are using. So in track 1, the reliever used is as needed low dose inhaled corticosteroid formoterol. So you can use this as needed low dose inhaled corticosteroid formoterol. That is coming in a single inhaler. That is, if you want to get the trade name, I will say that Areacode. That is from Cipla. And another thing is on is the butamate, which is coming from lupin. So here we are advising the MART therapy. MART therapy means for both reliever as well as controller, we are using a single device. So this is the track 1. So for track 1, for step 1 and 2, that is when symptoms are less than 4 to 5 days a week, for a mild case of asthma in age group 12 years and adults, what is advised is as needed low dose inhaled corticosteroid formoterol. Or for example, for a mild case in this age group, what you will do is that you just give an inhaler of Areacode. You give them Areacode and tell them that whenever you are getting symptoms, you take it for around 3 to 5 days. Or even when he is getting an acute attack of acute asthma, then the same device, same the MDI, he can use as a reliever also. So that is as needed low dose ICS for control. And if the patient is not getting control with this, then we have to proceed to step 3. There, what is advised is that you use the same MDI, but you use it on a daily basis. Low dose maintenance ICS for control. You use it on a daily basis for a minimum of 3 months. That is step 3. And even at step 3, the patient is not getting control, then you increase the dose of the same thing. You make it medium dose maintenance ICS for control on a daily basis. So if you are started with Areacode 100, that was a low dose. If you are not getting adequate control, you make it Areacode 200. So that is medium dose maintenance ICS for control. And the other options, when you're not getting control, then you have to step up to step 5. The other options are available. As I already mentioned, the main important drugs are tiotropium, omalizumab, mepolizumab, and dupilumab, but these are very, very rarely used. So this is track 1, and Gina is recommending as to use track 1. But anybody who wants to follow the old system means you give the patient one MDI for a reliever and another MDI as a preventer. If you are so particular that you will follow that old system only, then you can follow or use the track 2. So this is track 2. What is track 2? The severity classification and everything is same. So for track 2, the only main difference is that here we are using 2 MDAs. One MDA for a reliever and another MDA as a preventer. So here the reliever used is as needed short-acting beta agonist, as we previously used to take salbutamol inhaler. So salbutamol MDA as reliever, and preventase depends upon the step of the treatment. So for step 1, what is advised is take inhaled corticosteroid whenever SABA is taken. So take inhaled corticosteroid whenever SABA is taken. So for step 2 is you, just like we did in the age group 6 to 11 years, on a daily basis you use a low dose maintenance inhaled corticosteroid. So if you are started on this Areacode, you started on 100 microgram, you do it for step 2, and if the patient is not improving, you have to increase the dose. So you can the reliever used here is different. That is as needed short-acting beta-2 agonist. What about step 4? Step 4 is you increase the dose of steroid. So you make it medium or high dose maintenance ICS LABA. And all of these conditions in track 2, the reliever is same, it is salbutamol. So better you do not confuse with these 2 tracks. You follow the recommended one, that is track 1. So track 1, you just remember this. Here for 12 years above and for adults, you are using only one MDI, both as reliever and as preventer. That is, if you are using Areacode, you are using it as both as reliever and preventer. So that is about the age group 12 years and older. So you need not have to by heart any of these things. You just have to keep these charts ready in your tabletop, and when you want to, you can just refer this and tell. There is no need to by heart this. And other controller options for both these drugs. Here, some important points you have to note. So just see the other controller option. In step 2 onwards, Gina is advising to start SLIT. What is SLIT? SLIT is immunotherapy. So from step 2 onwards, that is a very, very important change that has occurred from 2021 onwards in Gina. That is, it is advising to use immunotherapy for asthma from step 2 for adults and adolescents. What is HDM sleep? I have it is kept that HDM sleep. HDM is house dust mite. So House dust mite is the most common allergen, indoor allergen, which is responsible. It is acting as a trigger for both allergic rhinitis and asthma. So, an immunotherapy, which is sublingual, done with the allergen house dust mite, has been advised as a second other controller option for the age group 12 years and on. So, that is a very, very important change in this algorithm. So that is about immunotherapy. So especially in patients with the asthma with an associated identified a single allergen, you can try a immunotherapy. Now coming to the age group less than 5 years. Less than 5 years, even though diagnosing asthma is very, very difficult. Many times you will be totally confused whether it is a case of pneumonia or it is a case of acute bronchiolitis or it is a case of asthma. You won't be able to arrive at a conclusion. Many of the times you will be just giving on the drugs based upon a probability based approach, and it is very difficult to make a diagnosis of asthma in the less than 5 years. What is the main reason? In less than 5 years, we cannot do the spirometry, and only after age of 6 years we can do spirometry. So it is very difficult to diagnose asthma. Even though it is difficult to diagnose asthma in this age group, treatment as per the algorithm is very, very simple because we only have very, very limited options at this age group. So you just see this thing. Step one, what is advice for step one? Step one, there is no need of any preventer. What is advised is that whenever you are getting symptoms, you take a short-acting beta agonist. So this is this age group. There is no change. There is no recent change. What has been what we were following for the last so many years is still kept like that only. So what is step one for? You just see the bottom of this. So if the symptoms are very, very infrequent, so for the infrequent viral wheezing, and if there are no or few interval symptoms, that means one, for example, an under 5 child coming to you with symptoms of VCLRS, they will be coming in January, they came with the symptom. And for 2-3 months, he was totally symptom free. And in April, he is again coming. So that means the symptoms are infrequent. So for such a case, for an infrequent viral wheezing, and if there are no interval symptoms, there you just need to give symptomatic management. What is the symptomatic management? You just need to give SABA, that is salbutamol inhaler only. But when the patient is getting recurrent attacks, every month is coming twice or thrice, then it is the time to step up to step two. For step two, you have only one option here, daily low dose inhaled corticosteroids. So you start the patient on this budesonide 100 micrograms BD. So what is the prototype? What are the situations where you start on step two? If the symptom pattern is consistent with asthma and asthma symptoms are not well controlled, that is more than 3 exacerbations per year, then you start here. Also, even if the symptom pattern is not consistent with asthma, but if the patient is requiring short-acting beta agonists very, very frequently, that is more than or equal to 3 per year, then also, even if you are not sure that the patient diagnosis is asthma, then also you can start daily low-dose inhaled corticosteroid. That is what is called as a trial of inhaled corticosteroid. So it is a trial, that is a therapeutic trial. It is just like doing an investigation. Also, what you are supposed to do is that when you are getting a frequent visa, means just like a patient I told, this patient came in January 2nd week, he came with symptoms, we treated him. January last week he came, February first week, February, March, every week, every month he is getting symptoms, night symptoms, everything is there. But all his symptoms are not consistent with asthma. You just suspect some other differential diagnosis. Even in such a patient, you can start a trial of inhaled corticosteroids. So what is supposed to be done is that you start the patient on Budecort or budesonide 100 micrograms BD, and you continue the treatment for 3 months. In between, at the end of 6 weeks, the patient is not getting any relief or the patient is worsening, then you have to think of alternate diagnosis. If the patient is showing improvement, you stop the treatment at the end of 3 months. And if the patient is worsening after stopping the treatment, then you can you will realize that it is probably a case of asthma. So that is a therapeutic trial. That is a diagnostic method. That is what is called as the trial of inhaled corticosteroid. So as I already told, there are very limited options in this age group. So step 2 is daily inhaled low dose inhaled corticosteroid. So what about step 3? The patient is not getting control with step 2, then you can go to step 3. It is nothing but doubling the dose of inhaled corticosteroid. So double low dose inhaled corticosteroid is what is advised. That is step 3. And in this age group, the less than 5-year age group, we do not have too much other options. So only two options is that daily low dose inhaled corticosteroid to in step 2, and if the patient is not improving, you double the dose to step 3, the double low dose ICS. So we do not have too much options in this age group. And other controller option is adding this Montelukast, that is leukotriene receptor antagonist. So that is if the patient is very, very unwilling to start an inhaled corticosteroid. Many times the patient, especially the parents, will be reluctant to start because they will be telling this is a very small child. Is it okay to start? In such cases, the patient, if you are not able to counsel them properly to start an inhaled corticosteroid, you can try using Montelukast. But Montelukast compared with an inhaled corticosteroid is very much inferior in efficiency. But this is a other controller option. So that is about the management of asthma in less than 5 years age group. Now you have started, whatever may be the age, less than 5 years, 6 to 11 years, or adult or adolescent, you have started the patient on some sort of preventive treatment. Then how will you follow up the patient? So first follow-up, once after starting the treatment, the first follow-up should be done 1 to 2 weeks after initiating therapy, and subsequent follow-up in monthly or once in 2 months you can do. And every visit, what are things you should do? You ask for the symptoms, how well his symptoms are controlled. So it is easy, or it is better that you use or maintain an asthma diary, which carries the details of how many days a month he is getting symptoms, how many times the drug is given, was there a need to go to a nearby hospital for nebulization. All these things you detail in a diary. That is what is called as asthma diary. Also check for adverse effects. So first follow up 1 to 2 weeks, and then regularly at least once in 2 months you have to follow up. And you have to keep this in mind. For most controller medication, including the inhaled corticosteroid, even though improvement begin within days of treatment, full benefit will take at least 3 to 4 months. So you have to counsel the patients regarding this. Even though you have started inhaled corticosteroid, for the patient to get a good effect, it will take at least 3 months. So this point has to be clarified with the patient. Now, when to step up and step down, I already told. You can, there is something called a short-term step up. That means, especially when the patient gets some viral infection, or if there is a chance of seasonal alveolinasthma. For example, in our place, during the monsoon, due to the cold climate, rain and all, there is a chance for an increased exacerbation. So for such periods, you can consider stepping up the treatment for 1 to 2, a short term of 1 to 2 weeks. And this long step up and all, I have already told. If the patient is not getting adequate response, you can step up the treatment. Whenever you are stepping up, any step up is considered as a therapeutic trial. If the patient is getting adequate response on stepping up, you are making sure that this is a case of asthma itself. Another important question, this is a point which all patients will be usually asking you: when to, how to stop the, how to cut down the dose of this. So when the patient is on ICS alone, that means the patient is taking only inhaled corticosteroid. Consider an example. The patient is on 400 micrograms of budesonide, BD. So how will you decrease the dose? The patient at the end of 3 months, if the patient is getting adequate symptomatic control, then what will you do? You can cut down the dose of ICS by 25 to 50% at 3 months interval. So if you have started 400 micrograms, after 3 months, if good control is there, you can make it 200 micrograms. But when you are using a combination of ICS and LABA, for example, if you are using Areacode, a combination of budesonide and formoterol, you have started the patient on 200 microgram, but what will you do to step down? So here you have to keep in mind a very, very important point. When we are using a combination therapy of ICS and LABA, always make sure that you are decreasing the dose of inhaled corticosteroid first. So reduce the dose of ICS alone by 25 to 50% and continue LABA. Please do not stop LABA immediately. After getting control, please do not stop LABA immediately. And first, you cut down the dose of inhaled corticosteroid. And when control is maintained in a low dose, very low, till low dose inhaled corticosteroid sufficiently, then only you think of stopping the long-acting beta agonist. So please do not stop long-acting beta agonist as a first step. And when the control is achieved at low dose ICS alone, switch to once a day budesonide therapy. So what about this MART? As I already told, in the in the adolescents and adults, if you are using the single maintenance and reliever therapy. So if you have started on a medium dose for Areacode, you make it low dose. If you have used a low dose for Areacode, what you are supposed to do, if you have started BD, make it OD. That is how you cut down the doses. This is another important question. Even on the day of starting the treatment, the patient will be asking, the parents will be asking, when will you able to stop this treatment? So this is very, very important. You have to keep in mind, once good control continues on low dose inhaled corticosteroid, that is step 2 regime, for at least 6 months. Even in the low dose inhaled corticosteroid alone, if the patient is getting very good control for a minimum period of 6 months, that is the time when you have to think of stopping the treatment. Then you have to counsel the patients regarding this. You have to continue the trigger avoidance, whatever the dust, cold climate, all these things, you are avoiding that, you continue avoiding that. And even after stopping, you follow up the child for 3 to 6 monthly period for at least 1 to 2 years. So you convey the point very clearly that even though you have started the treatment, at any point of time, there is a chance that the disease may come back, because there is a chance of a relapse. Asthma is you are not curing it completely. There is at any time it can come back. So restarting the regimen is not a failure of therapy. So it is a part and parcel of asthma management. This point you have to convey to the patient very clearly. So that is about the long-term management of asthma. So I have discussed this topic in 3 headings, 3 age groups, less than 5 years, 6 to 11 years, and adults and adolescents. But as I am doing this talk for a group of basically general practitioners, management of acute asthma is also very, very important. So I will be touching this topic only on the peripheral setup, not in the ICU, because we are not managing asthma at that level usually. So acute asthma management includes management at home as well as in hospital. So many a times the patient will be at home when he gets an acute attack, and you have to start the treatment from home itself. So home management, what is important is a thing like a written asthma action plan. So whenever you are discharging a patient after getting one exacerbation, or whenever you have started treatment for a patient, you just have to give this chart, a chart like this in the local language you have to give. So you tell the patient, you just give the details of the patient, age, name, everything, etc. And you tell them for what all symptoms you have to suspect an acute exacerbation. And when you are getting an acute exacerbation, what you are supposed to do at home. So a chart like this is you have to give, and that is what is called as written asthma action plan. So that is very, very important in the management of asthma. And what is advised to be done at home when you get an acute exacerbation is you give 4 to 6 actuations of short-acting beta agonist through an MDA with spacer. So 4 to 6 actuation through MDA with spacer is what is advised when you are managing an acute asthma. And you can repeat it for maximum of 3 times at 20 minutes interval. And you remember this, even at the end of 1 hour, you are not getting adequate response, you can start giving the first dose of oral steroid. Usually what is given is prednisolone. So this point, even though it is given in our recommendations, in our practical management, you won't be telling the patient to start steroid by themselves because there is a chance of self treatment and over management. So you can tell the patient to start short acting beta agonist, and if the patient is not getting adequate control at the end of 1 hour, they should attend a hospital setup. So acute asthma management in a hospital, the most important thing is that whenever the patient is coming to you, you have to grade the severity of the patient. So it is based upon what is called as the pulmonary score index. So pulmonary score index is based upon 3 criteria. That is respiratory rate, wheezing, and accessory muscle use. So respiratory rate, like this, you can see. If it is less than 6 years, less than 30, 31 to 45, like that, you have to score. Wheezing, when you are auscultating using a stethoscope, you just see whether the wheezing is present or not, whether it is present only at the end of expiration or full expiration is heard, or throughout the respiratory cycle, both in inspiration, respiration itself. Based upon that, you grade that. And third thing is accessory muscle use. So we know we have different accessory muscles, pectoralis, sternocleidomastoid, serratus anterior and all. And based upon these, we classify this. So these 3 indices are used: respiratory rate, wheezing, and accessory muscle use. And you score individually. And what is score between 0 to 3, you say it is a mild case of asthma. And score between 4 to 6 is a moderate case of asthma, and more than 6 it is severe case of asthma. And based upon the severity, we need to manage in a hospital setup. I think this classification is clear. It is what is called as the pulmonary score index. So those children whose score is more than 6, they should preferably be managed in a pediatric ICU. That is a severe case of acute asthma and should be managed in a pediatric ICU. Now, in the next few slides, I will very okay. So, which is the first drug that we will use in a hospital setup? Which is the first drug that we use in a case of acute asthma? The first drug which is advised is salbutamol. So, some problem in the slides. Okay. So, salbutamol in a hospital, how will you give? So, that is a very, very important point. Even in a hospital setup, if the child is not sick, if the patient is able to use an MDA with spacer, it is always better that you advise him to use a MDA with spacer. So if the SpO2 is more than 92%, you can advise the patient to use an MDA with spacer 6 puffs every 20 minutes or 1 hour. Every 20 minutes, you give 6 puffs. And 6 puffs means only 1 puff at a time, 1 minute interval between 2 puffs. So you give 1 puff into the inhaler, ask the patient to breathe in, wait 1 minute, and then give the second puff. Not like you give the 6 puffs together and ask the patient. So you have to do the 6 puffs separately. And if the SpO2 is less than 92%, you can think of using a nebulizer. And nebulizer, whenever you are using, always take care that you are using oxygen along with it, because there is a chance for this ventilation perfusion mismatch, and especially in a severe case of asthma, that can lead to worsening of the symptoms if not adequately done. So that is the first drug. This salbutamol. So that salbutamol, the nebulization dose, all of you know, less than 5 years it is 0.5 ml, and more than 5 years it is 1 ml. Nebulized respiratory solution, it is coming in a strength of 5 milligram per ml, and Respule it is coming as 2.5 milligram per 2.5 ml. So you have to remember one thing: Respule is an already diluted drug. It is already diluted with normal saline, so there is actually no need to dilute it again. So this is one mistake that we usually do. The Respule is coming diluted in normal saline, so you can use it directly. So nebulized or using an MDA with spacer, salbutamol is the first drug that you are using. And if the patient is not getting adequate response, then what will you do? Then you can think of adding the second drug, that is ipratropium bromide. So ipratropium bromide, you can either mix it along with the salbutamol, or you can give it intermittently. So every 20 minutes you give ipratropium bromide and salbutamol, either mixed or alternatively, and you can give a total of 3 doses. And then after these 3 doses, at the end of 1 hour, you can give after 6 hourly, not more than 24 hours. So ipratropium is not having any role after the first 24 hours. So you have to use it for a maximum of 1 day only. So if the patient has improved with this thing, you can step down the treatment. But sometimes even with using salbutamol and ipratropium, the patient may not be getting relief. Then we can use the third drug, which is the recommended drug here, is magnesium sulfate. So magnesium sulfate is a very, very effective drug. You can use even in our peripheries. This is comparatively very, very safe drug. The dose is 25 to 50 mg per kg. That is 0.1 ml per kg. IV slowly in normal saline, around 50 ml of normal saline. So this is magnesium sulfate given in IV. That is one drug which is recommended after using salbutamol and a combination of ipratropium and salbutamol. And other drugs, that terbutaline, aminophylline and all, even though it is recommended in some of the guidelines, it is not commonly used, and with the safety profile, especially aminophylline, is not that safe use. It is having a narrow therapeutic index. Actually, GINA is not recommending aminophylline from 2020 onwards. Aminophylline has been removed from the guidelines. Terbutaline, even though it is okay to use, but it is not freely available. So in our setup, in 99% of cases, the adequate symptomatic relief we will get with nebulized salbutamol along with ipratropium or not. And if not, we can use a magnesium. Even with these 3 drugs, along with oxygen, we will get adequate relief in all cases of acute asthma in our setup. Only if the patient is not getting adequate response to this, we need to refer the patient to a PICU setup. So that is about my presentation. But before stopping my presentation, I will rush through some important practice points in our day-to-day practice. Some commonly some about the drugs and the devices and all. So first important thing is which device to use. So the device to choose depends upon the age of the patient, how far the compliance is. All these things will affect the decision of choosing the device. But this chart, if you keep this in mind, majority of your confusions will go. You just see this thing. The second column is telling the drug deposited in the airway, and the third column is telling oropharyngeal deposition. So when you are considering asthma, the drug deposited in the airway is the drug which is going to be effective. So you just see this. And MDA with a spacer, the drug deposited in the airway is 10 to 20%. That is the highest amount which can be deposited using a device. But you see the lowermost thing, nebulizer, the drug deposited in the airway is 1 to 5%. So compared with the nebulizer, the drug delivery using an MDA with spacer is 10 to 20%, but nebulizer is 1 to 5%. Using a spacer is very, very important. You can see when you are using MDA alone, the drug deposited in the airway is 5 to 10%. It decreases by 50%. The dry powder inhaler, the deposition in the airway or the effective drug reaching the site of action is 5 to 10%, and it is not recommended below the age of 7 years also. So my the recommendation and my personal advice as per my practice is that as far as possible, even if the patient is an adult, you use an MDA with spacer, preferably an MDA with a valved spacer. MDA with a valve is a must, because that will, the effectiveness will improve if you are having a valve also. So this is a recommendation for the different age groups in which the devices are to be used. So less than 4 years, you have to use an MDA with spacer with a mask. A mask is a must less than 4 years of age. And after 4 years, if the child is cooperative and is able to do without a mask, you can use MDA with spacer. And after 6 years, you can use MDA with spacer or a breath actuated inhaler or a dry powder inhaler. As I already told, even though it is recommended that you can use all these devices beyond 6 years of age, but it is always better that you use an MDA with a spacer in all age groups. That is the most effective aerosol delivery system. This is another important point. How will you tell the patient to take the inhaler? Many times what happens is that you just write a prescription, PD got 100 micrograms PD, and you just leave the patient. Patient will be using it as a spray. He won't be even inhaling it. So you have to demonstrate the in front of the patient how to do this. So there are two mechanisms or two ways in which we can use the MDA with spacer. One is that you tell the patient to use a tidal breathing, especially for small children. They may not be able to keep the breath hold. So what you can tell the patient is that if you are using a valved spacer, you just breathe through the spacer and you give at least 6 breaths through the spacer. So what is exhaling won't go inside the spacer because there is a valve there. So you just give 6 inhalation and exhalation. So tidal breathing, that is one method. And second method, which is comparatively more effective, is a deep breath and a breath holding. You take a deep inhalation and breath holding. So this is a comparatively better drug delivery method, but especially in small children, you may not be able to make them understand the breath holding technique. So as far as possible, you make them do this method. But if the child is not cooperative, not able to understand what you're telling, you please make him do a tidal breathing. So you ask the patient to sit comfortably in a position, sit straight, use the inhaler, this spacer, and ask him to take a deep breath, and till you tell him to hold the breath for 10 seconds or till you count 10. 1, 2, 3, 4, 5, 6, till 10, you have to breath hold them. And after using this, you ask the patient to wash his mouth and throat. You have to give a small gargle with normal water, and that will prevent the deposition of the breath in your face. So this is an MDA with the spacer, you can see. So these are some of the common mistakes that happen in our day-to-day practice. One is not shaking the MDA before use. This is a very, very important mistake that should not happen, because we should understand that and in an MDI, the drug is, the amount of drug is very, very less. Majority of it is occupied by the air and the propellant. So nowadays, the propellant used is what is called as HFA, hydrofluoroalkane. So until and unless you shake the MDA before use, it won't get mixed up. So if you're not shaking and giving, only the propellant will go inside. So thoroughly shake the MDA before use. Not closing the mouth around mouthpiece. So after, if you are using the mouthpiece or if you are using the spacer, make sure that you are not leaving any space between the mouthpiece and the mouth, so that all the drug will go inside. Before using this thing, you make the patient exhale. You have to inhale deeply through the spacer, and if possible, ask the patient to hold breath for adequate time. And another important mistake is using an empty canister. Sometimes this happens. So the patient will be the sound will be there even after using it for 3 to 4 months, even after it is emptied. Whenever you press, the sound will come, but there won't be any drug inside. So always use an integrated dose counter. So if you are using an integrated dose counter, it will give you an idea when the drug is going to stop and all. So these are some of the common mistakes, and as a doctor, we should make sure that none of these mistakes are happening. And every visit, you make sure that you are demonstrating in front of the patient and make the patient demonstrate it in front of you in every visit. At least for the first few months, you make the patient demonstrate how they are using. So this may not be possible in our busy OPDs because we will be seeing daily 150 patients. We won't be able to demonstrate. But if you are seeing a lot of asthma cases, what you can do is that you can dedicate one day in a week for asthma clinic or allergy clinic, and then you can take the help of your nursing staff if you are willing, and you can train them also and make the patient. So even there are some pharmaceutical companies which are ready to give the demonstration in front of the patient on a monthly basis. So you can take their help also. What about mask? So when you are using a mask, I told less than 4 years you are supposed to use a mask. Always make sure that you are using a tightly fitting mask. If in this picture you can see the amount of drug deposited is drastically getting reduced when you are not using a tightly fitting mask. And another important point is that for face mask, we are using only less than 4 years, and after that, it is better that you use a mouthpiece directly. And this is the amount of oxygen flow rate that you are required to use. You have to use at least 8 liters per minute for an optimal drug delivery. Oxygen, you have to, if you are using oxygen as a thing, you use 8 liters per minute minimum. This is another common mistake that usually happens. Sometimes when you start the nebulization, especially for a child who is less than 3 years and all, the child will be crying, incessant crying, the child will be simply crying. So what sometimes we tell them that you keep the mask away so that the child won't cry, just keep it in front. So you have to keep in mind that once you keep the mask away, the drug delivered will get drastically reduced. So keeping it around, so depending upon the distance it is kept away, 1 centimeter distance to the mask may reduce the inspired dose by approximately 50%. If you're keeping it 2 centimeters away, 80% reduction. So what happens in our OPDs and all is that due to the system will just keep it, and the grandmother will be putting it opposite to the patient. The patient will be sitting somewhere, and after 5 minutes, the grandmother will go. So that is not this. What is called as the blow by technique is not advised. If you are using a mask for nebulization, you make sure that you are using it tightly fitting. The distance increases means that delivery will drastically decrease. So these are some of the practical points. So that is all about my presentation. If you have any doubts, I'm ready to take. Thank you so much for your patient listening. As I already told.